Good morning, everybody, and I welcome you all to this talk on diabetes mellitus and the common burden for comprehensive care. First of all, I would like to extend my sincere thanks to the Ceylon College of Physicians and Nawalapitiya Clinical Society for giving this opportunity to talk on this very common burden uh, in this country regarding a comprehensive care. I selected this topic because, as I say, it's a common problem for many of the medical officers. Almost all medical officers at various levels will come across diabetic patients under their care. So everyone who is a medical officer in this country should know well about diabetes. And unfortunately, I think diabetes in this, I think not only in Sri Lanka, even in many parts of the world is, managed suboptimally very frequently. So I would like to talk on this topic with the uh, with these points like background and burden of diabetes, level of care for diabetics, what is the comprehensive care, a care on diagnosis, and care during follow-up. Background and burden of diabetes. Diabetes is a chronic progressive disease with it's a metabolic disorder characterized by chronic hyperglycemia with disturbance of carbohydrate, fat, and protein metabolism. It involves fat and protein metabolism also. We have to remember in mind, and it causes significant, serious micro and macrovascular complications and significant morbidity and mortality. Furthermore, diabetes is a growing problem in Sri Lanka. It's a pandemic worldwide, we know that. And currently, about 13% of Sri Lankans are diabetic, and it's predicted to be 25% by 2040. And diabetic related complications are common and claims high portion from an annual health budget of Sri Lanka. The prevalence of diabetes in Sri Lanka has shown uh, a rising trend. We can appreciate this from this data is from 1988 to 2008, where you have seen a significant, rising trend. Apart from that, also this interesting fact is that it's rising. The prevalence in the elderly population is also rising. If it is, once you become elderly, the chances of you becoming a diabetes is also high. So you mean you have a chance about more than 20% you become a diabetic when you are at your 70s. So we know already the Sri Lankan elderly population is rising. We have a burden of elderly population. So now, along with that, if we have diabetes, with this elderly population, you can imagine the burden which we can have in this poor country. So we just would like to say who are involved in carrying diabetes. We know in Sri Lanka we know people diabetics care themselves. They manipulate their treatment. They decide, they and their family members decide on treatment. It is a very dangerous situation. And also, very frequently we come across people go to the pharmacies and get the medications and just continue diabetic medications. And we know that there are indigenous physicians who treat diabetics. And most importantly, we have general practitioners and medical officers at various levels treating diabetes, who are the main, I think I would say the vast majority of the diabetics are treated by this group, I would say. So This is why I thought I should uh, confine my lecture to give some knowledge or some give their refresh their previous knowledge and give the sort of principles of standard care to these uh, medical officers who are working at various levels. And we know we consultants and physicians and endocrinologists also treating diabetes. These are the categories of health care, I mean diabetic care a patient can receive, where we should strongly discourage self and family members and pharmacists treating diabetes. So the quality of care varies where the patient stands. So comprehensive care about of diabetes, when you say, we should aim at comprehensive care at all levels to prevent significant morbidity and mortality. Since diabetes is a common chronic progressive disease, it's not going to stop. Comprehensive care should address all aspects and elements of diabetes and its related complications. So therefore, continuous, planned, proactive, patient-centered care is essential, where also a population-based care should be given. Therefore, primary healthcare system as well as secondary and tertiary healthcare system should be well prepared to give a very comprehensive care to these diabetics. So, at diagnosis of diabetes, certain things we must address. We must always take a good history about family history and psychosocial and lifestyle of the diabetic patients at diagnosis, and search for infections where they very frequently come with complications like infections, fungal infections, abscesses, and cellulitis, UTI, and so on. When patient present with these infections, you always should look for a presence of diabetes as well. And we screen for other NCDs and metabolic syndrome. Many, about 30% of diabetics are unaware about their presence of diabetes in them. Hence, when presenting, they can have already complications. Now, diabetics, type 2 diabetes can, unlike type 1 diabetes, type 2 diabetes can run without symptoms for months and months. So, where the complications would have been set in when the patient present with the at the diagnosis. This is where we have to screen for micro and macrovascular complication at the time of diagnosis. So also we should give overall risk assessment at cardiovascular risk reduction effort at diagnosis as well, at the point of diagnosis as well. And there is strong association with metabolic syndrome, about diabetes. So if it is a diabetes, it is not only diabetes. You have to look for other, associated uh, features of metabolic syndrome like fatty liver disease, which is very common at the diagnosis, even at the diagnosis of diabetes, and cardiovascular disease and coronary disease, and other metabolic syndrome related disease like OSA and PCOS and so on. So look for signs of metabolic syndrome like acanthosis nigricans and obesity and central obesity and so on. So at the time of diagnosis, you should aim a good health education program, aiming a very good lifestyle modification with diet and diet control and exercise and cessation of smoking. Where the patient, when you talk about diet control, you can arrange individualized diet control system. But if there is a dietitian or expert on that field, otherwise you can you can achieve, you can advise on salt and calorie and fat restriction, and allow about or advise about 10% weight reduction if overweight, if the patient is already overweight or obese. And patient compliance and motivation should be encouraged at the time of diagnosis itself. And at the time of diagnosis, you also should aim at the tight glycemic control to ensure future better control and prevent microvascular complications. There is something called metabolic memory or legacy effect, where if you control the glycemia at the outset, that will give a good metabolic memory, which will have a better impact at the later life. So you have to target a good glycemic control at the outset itself. Often, the patient will come with a very high sugar level at the diagnosis, 300, sometimes 400 bc, where the glucose toxicity will have a bad implication and the pancreas and islet cells. So these people might need insulin at the outset. So you'll have to start you have to control the diabetes at that point, even at the diagnosis, time of diagnosis, aggressively with insulin. A few words about essential medications in diabetics. All the patients who are diabetics should receive metformin as a first line treatment. So second line, a patient can be put on sulfonylurea, which is mostly available and is a very good drug in view of controlling diabetes. Alternatively, SGLT2 inhibitors like empagliflozin, DPP4 inhibitors, sitagliptin-like, and GLP-1 receptor agonist, alpha-glucosidase inhibitors like acarbose, and thiazolidine like pioglitazone can be used as alternatively. These drugs, any of these drugs can be taken as second line drug, but usually in our setup, after metformin, you can combine second line drug as sulfonylurea as a second line drug. It is cheap and it gives a good control as well. And also a few words about empagliflozin, which is a recently available in the market, which is a very good drug. Nowadays, also the guidelines would many of the guidelines would suggest recommend it for the first line drug itself, because it has a cardiovascular clear cardiovascular benefit in diabetes. So the main issue is it's very expensive. For the country like us, I think the guidelines does not allow as the first line for many of us. So otherwise, empagliflozin or the SGLT2 inhibitors is a good drug, as of even can be used as a first line drug as well. So if you have bad control, you can combine drugs, metformin, sulfonylureas, any of these drugs, and also then you'll have to, if the patient is not controlled, then you have to start on insulin augmentation dose with basal insulin at a nighttime dose to get a good glycemic control. So sometimes even with that, if you don't have a better control, then you have to go for complex insulin regime with multiple doses, where it should be handled by an expert like endocrinologist or a physician. Therefore, when you are selecting drugs or medications for diabetics, certain things you have to bear in mind. One thing is whether this drug has CVS benefit, because the diabetes itself is independent risk factor for cardiovascular mortality. So all what is recommended is we always see with this patient whether the drug has any serious benefit, or at least if it is safe in terms of serious cardiovascular event. And think about weight neutrality and the risk of hypoglycemia, the cost, renal function, and usage, the possible usage in heart failure, hepatic failure, and so on. So these are the principles you must have when you're selecting oral hypoglycemic drugs, when you're selecting. And generally, all diabetic patients who are more than 40 years should receive statins on their drug list. Aspirin previously the diabetics received aspirin, but the current guidelines does not recommend aspirin for all diabetics unless they have two or more other risk factors. But we tend to see many of the diabetics, in the practice, many of the diabetics have aspirin in their, drug list. So during follow-up, our goal should be prevent complications like micro and macrovascular complications, and also reduction of cardiovascular event. So you should have a good glycemic control. You may aim at a good glycemic control at all time in the management and follow-up, during follow-up. So all microvascular complications can be prevented with good glycemic control. We have strong evidence with UKPDS and DCCT, large randomized control trials. So we must be convinced as medical officers, or we are doctors, medical professionals, we must convince that if we can ensure the good glycemic control in our patients, we are going to prevent a huge burden for the person and for the country even, because health cost of managing diabetic related microvascular complications, maybe CKD or maybe other retinopathy or whatever it is, right? It is with a very high cost. So therefore, we must be convinced that our aim should be to one of the main aims should be to prevent microvascular complication, and also the patient should be educated about this factor. Therefore, we need to set good targets, and we must do routine screening for complications. So preventing further deterioration. If you have complications, if you detect complications, you must at least try to prevent further deteriorations, and you must arrange proper and timely interventions and referrals. I have worked in many peripherals as a consultant, but and in my experience, I have seen a lot of very often we get very complicated patients who are managed at peripheral hospitals without supervision for a long time, coming with very bad complications without being properly managed. So with this, one thing is you need to know that you need to do a routine scanning for complications, and how to detect them, and you must be sincere enough to refer the patients to the expert. So furthermore, setting targets, when you're setting targets, is glycemic targets is very important. As I said, your fasting blood sugar, you can aim at 80 to 130 milligrams per deciliter, and ppbs levels 130 to 180, and HbA1c, of course, it's a range from 6.5 to 8. You know, it's, in patients who are young patients, who have well motivated, and you who have no comorbidities or less comorbidities, you must aim 6.5 HbA1c level, HbA1 levels, and patient is elderly. If the patient is an elderly patient who has more comorbidities and well not well motivated, you can allow about 8 HbA1c. So generally, HbA1c of 7 is acceptable. In Sri Lanka, we go for 7 as 7% as the HbA1c. If you can achieve at least 7 is good enough, I think. And blood pressure control, it should be, all diabetics should, their blood pressure should be less than 140 by 90. If they have proteinuria or microalbuminuria, it should be less than to at least 130 by 80. So you have a lipid target of less than 100 mg per deciliter. So when you say screening for complications, screening for retinopathy is important. Retinopathy prevalence is about 30% in type 2 diabetes and 70% in type 1 diabetes. So it can be present, retinopathy can be present at diagnosis itself in type 2 diabetes. So it can be asymptomatic as well. So it should be borne in mind that at the time of diagnosis, you must do some screening, all diabetics for retinopathy. At least some history of blurred vision, of seeing floaters, or eye pain should be asked, and all patients should have at least visual acuity test, a fundoscopic examination with dilated pupils. So any abnormality, if you find, you need to do a eye referral, and annual eye surgical review is an essential in all diabetes. And other thing is, in all diabetics who have nephropathy, always look for retinopathy, because we know that retinopathy precedes nephropathy. So next is the nephropathy screening. During a follow-up, always ask about history, about proteinuria or proteiuria, and you need to do a UFR. Always do you do a UFR before doing a urine microalbumin. We have seen this also. These people ask for straight away urine microalbumin, which is a wrong, I think, investigation to ask for first, because if you have UFR albumin positive, you don't need to ask for, you need to look for microalbumin, because it's more than 300. So that means your microalbumin level is already past. So you ask for UFR always, I mean, as a first thing, and if it is negative, only ask for urine microalbumin. And the thing is, urine microalbumin test is also expensive, unlike UFR, simple UFR. So you also must know when to test for proteinuria. So and it should be confirmed with 3 occasions, at least 3 to 6 months before you label somebody as to be having proteinuria, because transient proteinurias are very common. So therefore, you need to start ARB-OLC because if you find urine microalbuminemia, to prevent overt proteinuria, because this stage you can reverse the proteinuria, where if it progress to overt proteinuria, I think you may not be able to reverse it, and ultimately the patient might end up in end-stage kidney disease in 7 to 10 years. So your aim should be to catch up the patient at least at microalbuminuria. And also polyuria and nocturia should alert you, because initially the patient, when there is a glomerular damage or a glomerular involvement, the patient might become polyuric, or because of the hyperfiltration of the kidneys. So if you have a polyuria nocturia, you should always think about renal involvement of nephropathy and screen for EGFR, ask for an EGFR. Therefore, you should ensure good glycemic and BP control, and and complete abstinence from smoking in the management of diabetic nephropathy. Apart from the initiating ACE inhibitors or ARBs. This is another slide I just want to tell when you should not ask for proteinuria, because this is also one of the very common mistake people used to do, asking for proteinuria, or UFRO, or seeing for proteinuria in wrong time. When somebody is having a hyperglycemia or high blood pressure, after exercise, or fever or urinary infection, or patient is menstruating, they can have transient some amount of proteinuria. So during this circumstance, you must avoid asking for or screening for nephropathy, which will be a waste of resources and your time. But the thing is, when you're following up, you must screen for autonomic neuropathy, basically, and other neuropathies. More importantly, is autonomic neuropathy. They can present with partial giddiness, very common, I think, in diabetics, or orthostatic hypertension, gastritic sweating, gastroparesis, and other GI upsets. And this thing, erectile dysfunction, though we don't, many of us don't ask about this, and the patients also are not very keen to, complain about this because of the cultural issues, right? To see, I think it's more than 30% of the diabetics. It's significant, right? This is very significant. About more than 30% of the diabetics have erectile dysfunction. So, if you have, if you voluntarily ask only, I think they will come up. Most of the patients are like that. So you need to address that if somebody has ED, and also there is association with, when you find erectile dysfunction, they have shown that there is association with coronary artery disease. So probably you have to, in a patient with ED, erectile dysfunction, you have to screen for coronary artery disease as well. So likewise, you need to, if somebody is having autonomic, any evidence of autonomic neuropathy, also look for uncomplained or asymptomatic coronary artery disease, or hypoglycemic unawareness events. So, few things about macrovascular complications of diabetes. There's strong association with atherosclerotic vascular disease in diabetics. Like coronary artery disease or cerebrovascular accidents or peripheral artery disease. And 2/3 of diabetics die of cardiovascular event. It's a very huge burden. And diabetics has threefold risk of myocardial infarction. So you must have a low threshold to screen and intervene for coronary artery disease in diabetics. I mean, I would say that you can over investigate or over suspect, coronary artery disease in diabetics. And macrovascular complications management, I think you must manage all additional risk factors for macrovascular complications like hypertension, smoking, dyslipidemia in diabetics. We must start statins, as I said previously, in view of combating macrovascular complications or coronary disease. All diabetics should receive a statin if they are more than 40 years of age. Can be high intensity statins. It should be a high intensity statins if the patient is already a non-patient with coronary disease. About aspirin, few words about aspirin. Diabetics who are not pre-existing, who has no pre-existing coronary disease, I think they previously mentioned they don't need to be on aspirin for antiplatelet therapy. But you can do a 10 years CVS risk assessment and see if the patient is having more than 10% risk for a cardiovascular event in a diabetic. You can start aspirin on such patients. Generally, diabetic patients who is in age more than 50 years, who has at least one risk factor, would be a candidate for an aspirin or antiplatelet drugs. So, other thing is ensure oral hypercarbonate drugs chosen as I previously said, as a CV benefit or a safety in diabetics in view of preventing cardiovascular event. Routine food care is also an important part of diabetes management. We know diabetic foot disease or diabetic ulcers are due to combination of factors. It's due to vascular and neurological and altered biomechanism and abnormal weight bearing resulting in foot deformities and foot ulcers causing diabetic foot disease. Therefore, you need to look for all of these components like neurological, how the foot is neurologically and vascularly, and what is the shape of the foot, whether there's deformity and so on. It's a holistic approach for a diabetic foot care. And diabetic peripheral neuropathy is a major risk factor for foot complication. Always look for. Do a good history and examination and investigation. You must always do ankle jerk, cross prescription, sensation, pinprick sensation. If available, do a monofilament test, which is more sensitive than a pinprick. A vibro check with a tuning fork or a biothesiometer if it's available. And if you have facilities, do a ankle brachial index, ankle brachial pressure index to screen for peripheral artery disease. So, if you find a diabetic foot problem, actually it should be intervened very early and to prevent, further damage and amputations. So, I'm coming to the last slide of my talk. I would like to give a take-home message to you all. As I said, diabetes is, I think, though it's a common burden, common problem, very often it is suboptimally managed. Therefore, comprehensive care of diabetes should aim at achieving good glycemic control. Preventing, our aim should be to prevent macro and microvascular complications and other complications. We should we should regularly do screening and do timely interventions and have arrange a good, a decent follow-up for the diabetic patients. With that, I conclude. My references are based on mainly with the guidelines, practical guidelines of Ceylon College of Physicians 2018 and American ADA guidelines, and few points from the Wikipedias and necessity trials. Thank you very much for kind listening.